Welcome back to Session 1, Part B of Cardiology Academy. In this presentation, I'll review the normal structure and anatomy of the heart. Here's where we are on our course roadmap. Before we get too far into anatomical considerations, we must be sure that we're all on the same page regarding nomenclature we use to orient tests in three-dimensional space as we discuss anatomy. We define three principal planes, each at right angles to each other. The right angles are termed orthogonal in three-dimensional space, as shown here in green, purple, and red. To start off, the coronal plane, otherwise known as the frontal plane, indicated here in purple, is any cross-sectional plane that cuts through the anatomy as if you were looking at the subject from the front. This is nicely demonstrated on this coronal slice of a chest CT, which includes the heart in the middle. The image is oriented so the person's right is on the left and left is on the right, a mirror image, so to speak. In this view, the direction towards the head, which is termed cranial, is at the top, and direction towards the feet, which is termed caudal, is at the bottom. The next plane, that is probably the most common plane used in CT imaging, is the transverse plane, which is also known as the axial plane, shown here in green. Here is a CT scan of the chest, including the heart in the middle by convention when we slice through the axial plane. We project the images as if we were looking up on the plane from the feet. This preserves the mirror image effect with the patient's right on the left and the patient's left on the right. Imagine that you were looking up from the patient's feet with the patient supine on the table looking up. The patient's front, which is termed anterior, is at the top of the image, and the patient's back, which is termed posterior, is at the bottom. The final principal plane is termed the parasagittal plane and is any slice through anatomy from front to back, dividing the anatomy to a left and right half as shown here in yellow. The corresponding CT image shown here is projected as if you were looking at the patient from the side. By convention, we usually show anterior on the left and posterior on the right, with the cranial direction towards the head at the top and caudal direction towards the feet at the bottom. The parasagittal plane that divides patients exactly in half is known as the median sagittal plane, as shown here in red. Let's get oriented to the heart with respect to its relationship to surrounding structures. I'll start with the anterior view of the heart as if we were looking at the heart from the front of the patient. The heart is situated in the thorax, in the central compartment of the thorax termed the mediastinum, as shown here. In turn, the mediastinum shares the thoracic cavity with the lungs. The heart is enclosed by a pericardial sac, which consists of an outer fibrous layer and an inner double-layered serous membrane, as shown here in light blue circling the heart. The mediastinum also contains critical structures including the superior vena cava, aorta, and pulmonary artery, as shown here, as well as the trachea and thymus gland in the superior mediastinum, which is shown here. The entire mediastinum is surrounded by the visceral and parietal reflections of the dual-layered pericardial and pleural surfaces. The parietal surface surrounds the lungs and pericardium itself, whereas the visceral reflection surrounds the structures around, including the chest wall and the heart. Since the pericardial surface and pleural surface are dual-layered, they each have potential to accumulate fluid between these layers. Abnormal fluid accumulation between the pericardial layers is termed a pericardial effusion, and between pleural layers is termed pleural effusion. The thoracic cavity is bounded by the diaphragm caudally and chest wall elsewhere. Now let's look at the anatomic relations of the heart from the side using the sagittal projection. Imagine you're looking at your patient from his or her left side, so the patient's front or anterior is on your left and back or posterior is on your right as shown here. Of course, the head will be at the top and feet at the bottom. In the sagittal projection, the heart is situated in the anterior mediastinum and rests just on top of the diaphragm. Notice the aortic arch, which is shown here in green, makes a 180-degree turn from caudal to cephalad, traveling towards the feet between the esophagus and spine, as shown here. Here is a very nice CT correlate of this sagittal anatomy. I'd like to make sure we're all on the same page as we discussed the systemic circulation served by the left ventricle and pulmonary circulation served by the right ventricle. Blood flows through the body in a figure 8 circulatory pattern, passing through the heart twice with one full circulatory cycle. Let me walk you through one circulatory cycle, starting with the venous blood, which is deoxygenated blood, shown here in blue, returning to the right side of the heart via the superior and inferior vena cavas. I will indicate direction of blood flow with green arrows. Next, the blood enters the right heart and makes its way through the right atrium and right ventricle, which pumps blood to the lungs, through the pulmonary arteries, which repetitively branch down to the microscopic capillary network, where the blood picks up oxygen from the alveoli in the lungs and leaves the lungs in the pulmonary veins and oxygenated blood shown here in red. Note that the pulmonary arteries are the only arteries in the human body that contain venous blood, and that the pulmonary veins are the only veins in the body that contain arterial blood. That's because the lung is the only organ in the human body that adds more oxygen than it removes, given its primary function to support human gas exchange. Next, the arterial blood returns to the heart through the pulmonary veins entering the left atrium and then moves through the mitral valve into the ventricle, where it is then ejected during left ventricular systole, through the aortic valve, into the aortic root to enter systemic circulation and travel with oxygenated blood towards vital organs where oxygen is consumed. This completes the figure 8 once blood travels around the body, returning on the venous side back to where we started. Now, let's turn our attention to the normal cardiac anatomy, starting with the aorta, the main artery leaving the heart to supply blood to the entire human body. After the aortic arch, the aorta continues as the descending aorta towards the lower extremities. The main pulmonary arteries, which send blood to the right and left lungs via the right and left pulmonary arteries, is shown here. After blood picks up oxygen from the lungs, it returns back to the left atrium via 4 pulmonary veins. The superior and inferior right pulmonary veins return blood from the right lung, and the superior and left pulmonary veins return blood from the left lung. Finally, venous blood returns back to the right heart from the systemic circulation via the superior vena cava and inferior vena cava from below. Now let's review the 4 main cardiac chambers. The heart is essentially 2 hearts working as one. The right heart receives deoxygenated venous blood from the systemic circulation into the right atrium. Then the blood is pumped by the right ventricle to the lungs via the pulmonary arteries. Likewise, the left heart receives oxygenated blood from the lungs into the left atrium. Then the blood is pumped by the left ventricle to the systemic circulation via the aorta and its branches. Finally, let's review the anatomic position of the 4 cardiac valves. The principal function of cardiac valves is to ensure blood moves forward. An inadequate opening of these valves is termed stenosis, where an incomplete closure leads to valvular insufficiency due to regurgitation of blood flow in the wrong direction. On the right side of the heart is the tricuspid valve, which lies between the right atrium and right ventricle. This valve is open during diastole to allow blood to flow into the right ventricle from the right atrium, then closes during right ventricular systole to assure no backflow during right ventricular contraction. The pulmonic valve lies in the right ventricle outflow tract to assure blood flows in one direction out of the right ventricle into the pulmonary artery on the way to the lungs. This valve normally opens during right ventricular systole and closes during diastole. The aortic valve lies in the left ventricle outflow tract to assure blood flows in one direction out of the left ventricle into the aorta on the way to systemic circulation. This valve normally opens during ventricular systole and closes during diastole. The mitral valve lies between the left atrium and left ventricle. This valve is open during diastole to allow blood to flow into the left ventricle from the left atrium, and then closes during left ventricular systole to assure no backflow during ventricular contraction. Now let's take a close look at the layers of the heart wall and pericardium. Let's zoom in on a representative section of the ventricular wall. The myocardium is the main muscular layer of the left ventricle. In healthy individuals, myocardial wall thickness can be up to 15 millimeters, although the wall thickness varies within the heart. For example, the wall thickness tends to be the thinnest at the apex of the heart. The endocardium is the innermost layer of the heart, lining the chambers and extending over the four cardiac valves, chordae tendineae, and papillary muscles. The endocardium is comprised of three distinct layers. The innermost layer, the endothelium, is a single layer of flat endothelial cells in direct contact with the blood-filled chambers, allowing a smooth surface for blood to flow across. The middle elastic layer is comprised of a mixture of smooth muscles and collagen. The subendocardial layer contains loose elastic tissue, collagen bundles, nerves, and small blood vessels. The endocardium also contains Purkinje fibers, which stimulate the myocardium to contract. The visceral layer of the epicardium, the outermost protective layer of the heart, is composed of mesothelial and connective tissue. The parietal layer of the epicardium is the outermost layer of the epicardium and has an epithelial layer, shown here in pink, abutting the pericardial space, and an outermost strong fibrous layer on the surface that helps anchor the heart in place. The visceral and parietal layers is separated by the pericardial cavity. This space usually contains between 15 and 50 milliliters of pericardial fluid. In pathologic states involving either elevated hydrostatic pressure, such as seen in heart failure, or increased permeability, such as seen in inflammatory, infectious, or malignant processes, a large amount of fluid can accumulate, causing significant pericardial effusions. Pericardial effusions may be asymptomatic, quite symptomatic, or lead to severe hemodynamic compromise as the pressure in the pericardial space rises through a process known as cardiac tamponade. We will discuss the physiology of tamponade during our review of hemodynamics. It's important to recognize that the pericardium reflects one surface to create the two surfaces I just described. In other words, the visceral and parietal layers are really just one surface that turns around at the top and bottom of the mediastinum. Let's look at some more structures and vessels that can be seen on the anterior surface of the heart. The auricle of the left atrium, also known as the left atrial appendage, is a small, pouch-like structure on the top of the heart that extends from the side of the left atrium. It's shaped like a windsock and is derived from the left wall of the primary atrium during embryonic development. The left atrial appendage can act as a decompression chamber when atrial pressure is high. Pooling of blood in the LAA can lead to a clot, which may enter the circulation systemically, leading to strokes and other systemic embolic phenomena. The left main coronary artery comes directly off the aorta, just below the left atrial appendage. Then, immediately branches into the circumflex artery, which runs laterally in the anterior groove, and the left anterior descending artery, which runs anteriorly in the intraventricular groove. On the right side of the heart, the right coronary artery comes off the right lateral wall of the aorta and runs laterally in the interatrial groove. Let's turn our attention to the posterior view of the heart to see cardiac structures from behind. The posterior interventricular artery, also known as the PDA or posterior descending artery, is the only one of the four major coronary arteries that does not arise from the aortic root or the LMCA. In about 70% of patients, this artery arises as a branch of the RCA. These patients are termed right dominant. 10% of the patients have their PDAs rising off the circumflex artery and are called left dominant. The remaining 20% are supplied by branches off of both the right and left coronary arteries and are called co-dominant. In spite the name posterior descending artery, this artery is more inferior than posterior. The coronary sinus drains over half of the venous runoff from the heart into the right atrium. As I mentioned before, the pulmonary arteries are the only arteries in the human body that carry deoxygenated venous blood as the right ventricle pumps venous blood that has returned from the superior and inferior vena cava to the lungs to oxygenate. Likewise, the four pulmonary veins comprise the only venous system in the body that carries oxygenated blood back to the left atrium, which is relatively posterior structure adjacent to the esophagus. Blood flow from the pulmonary veins is maintained by a pressure gradient between the pulmonary capillary bed and the left atrium. This pressure gradient is actually generated by the RV. About 2/3 of the pressure gradient is dissipated in the precapillary arteries and arterioles, and the remaining third of the pressure gradient is dissipated in the postcapillary veins and venules between the pulmonary capillary bed and the left atrium. I would like to briefly review the main branches off the three principal coronary arteries. First, starting with the LAD or left anterior descending, which as you may recall is a branch off the short left main coronary artery that runs down the anterior surface of the heart in the interventricular group as shown here. This artery gives off large diagonal branches typically numbered sequentially D1, D2, which are diagonal 1 and diagonal 2. Several septal perforated branches serve as a blood supply to the anterior ventricular septum. Finally, in about 15 to 30% of patients, the distal main coronary artery trifurcates into a third branch. It would be difficult to call this a branch off of either the LAD or the circumflex because it comes off at a point where the left main bifurcates into the LAD in the circumstance, effectively trifurcating off of the left main. So this is simply called the ramus. The left circumflex artery is the second of the two main branches off the left main coronary artery. This artery runs down the intraatrial groove laterally and wraps posteriorly as shown here. The circumflex artery gives off marginal branches as shown here. These can be labeled M1 and M2. Here is a schematic diagram of the principal coronary arteries, their branches, and ventricular geography that they supply. In normal anatomy, only two arteries directly come off the aorta, the left main coronary artery and the right coronary artery. The left main coronary artery is a short artery coursing only 20 millimeters or less, then immediately bifurcating into the LAD and circumflex. These two arteries and the right coronary artery comprise the principal three coronary arteries. As I mentioned a few slides back, between 15 and 30% of patients have a ramus branch coming off the left main at the bifurcation of the LAD and circumflex. The posterior descending artery, which is located in the posterior intraventricular groove, is a branch off the right coronary artery 70% of the time, and a branch off of the left coronary about 10%, and off of both about 20%. Patients whose posterior descending arteries come off the right coronary, as I mentioned, are right dominant, and vice versa. Most of the heart is supplied by branches off of these coronary arteries, as mentioned. For example, diagonals come off LAD, marginals off of the circumflex and RCA. Different regions of the myocardium receive blood from branches of what is somewhat predictable, although at times modestly variable fashion. The intraventricular septum receives blood from the diagonal branches of the LAD, and as I mentioned, septal perforators as well. The left ventricle, which contains about 60% of the LV muscle mass, so has a very varied source of blood supply. The anterior wall takes its blood supply principally from diagonal branches of the LAD. The posterior and inferior wall takes blood from the posterior descending artery, and in some cases, not shown here, the circumflex. The right ventricle takes its supply from marginal branches off the right coronary artery. The SA and AV nodes, which are specialized myocardial cells with the principle of automaticity, takes its blood supply from the RCA, so that patients with right ventricular infarcts related to RCA occlusion frequently have marked SA and AV nodal dysfunction. The myocardium is comprised principally of cardiac muscle cells that reside on a framework of collagenous fibers, blood vessels that supply the myocardium, and nerve fibers that regulate the heart. The muscle pattern is elegant and complex, with the muscle bands swirling and spiraling around the cardiac chambers of the heart, forming a figure-8 pattern around the atria and around the bases of the great vessels. Deeper ventricular muscles also form a figure-8 around the two ventricles and proceed towards the apex. This complex swirling pattern allows the heart to pump more effectively than a simple linear pattern would. The myocardium in the left ventricle is significantly thicker than the right ventricle. Both ventricles pump the same amount of blood each minute, but the left ventricle must generate a much greater pressure to overcome greater resistance in the systemic circuit, as the mean arterial pressure is usually 70, while the mean artery pressure in the pulmonary artery is usually 20. Here we see the right and left ventricles sliced just off the transverse plane during the relaxation diastolic phase, showing the relative thickness of the LV wall compared to the RV wall. During systolic contraction of the two ventricles, here in healthy patients, over 50% of the blood is ejected, creating a significantly smaller residual lumen at end systole and significant wall thickening of both ventricles compared with diastole, which is the resting phase of the cardiac cycle. In this slide, let me orient you to some of the principal internal cardiac structures. The mitral valve lies between the left atrium and left ventricle, allowing one-way blood flow from the left atrium to the left ventricle during left ventricular diastole. The aortic valve is a one-way valve lying at the base of the heart, allowing blood to leave the left ventricle to enter the systemic circulation via the aorta. The interventricular septum is medially situated and separates the left heart, which is comprised of the left atrium and left ventricle, from the right heart. The tricuspid valve allows one-way blood flow from the right atrium to the right ventricle during ventricular diastole. The chordae tendineae tether the mitral and tricuspid valves by way of the papillary muscles to the respective ventricular cavities. Mechanical disruption of the chordae or papillary muscle dysfunction may lead to significant mitral or tricuspid valve insufficiency. The fossa ovalis is the anatomic remnant of the foramen ovale, which was an open connection between the left and right atria prenatally. This should close at the time of birth or shortly after birth. Failure for this connection to close leads to a patent foramen ovalis, which is a cause of interatrial blood shunting and a cause of paradoxical left-sided emboli, as systemic emboli returning to the heart have a pathway to cross into the left-sided circulation. This illustration shows the view of the base of the heart during diastole looking up from the feet towards the head, with the heart sliced in a transverse plane while the patient is lying prone, which is face down. At this level, we see the tricuspid and mitral valves are posterior. The aortic valve is central, and the pulmonary valve is most anterior. Here is the coronal view of the left ventricle during systole, showing the open aortic valve and mitral valve in closed position. As I mentioned on the prior slide, during systole, the mitral valve is held closed by contractions of the papillary muscles contracting, pulling on the chordae tendineae. Here is the corresponding gross pathology of the heart sliced in a similar coronal plane, showing the actual appearance of the chordae tendineae and papillary muscles. There is one other important internal structure worth a mention here: the trabecular carneae, which are large cone-shaped muscle bands in the lining of the left ventricle wall. The trabeculae carneae streamline blood flow by preventing suction that would occur if the valvulus wall was smooth. Also, in a similar fashion to the papillary muscles, during ventricular systolic contraction, the trabecular carneae pull on the chordae tendineae, maintaining valvular integrity. Finally, the trabeculae are important in cardiac electrophysiology. A condensation of trabecular fiber forms the moderator band, which carries the right branch of the bundle of His. No talk about cardiac anatomy is complete without at least mentioning several common congenital cardiac anomalies. An extensive discussion of congenital heart disease and its management is beyond the scope of this course. First, a patent foramen ovale is an abnormal opening in the interatrial septum, or more commonly, a failure of the foramen ovale to close after birth. This can lead to intracardiac shunting and paradoxical systemic emboli, where blood can cross from the venous circulation through the PFO to the arterial circulation and cause systemic emboli, including stroke and peripheral emboli. Second, coarctation of the aorta is an abnormal narrowing of the aorta. The ductus arteriosus is a blood vessel that connects the pulmonary artery to the aorta in a fetus, which allows oxygenated blood to bypass the lungs. After birth, the ductus arteriosus usually closes within a few days. Incomplete closure is termed a patent ductus arteriosus, or PDA. Complications of PDA include CHF, infective endocarditis, pulmonary hypertension, and neonatal failure to thrive. Finally, tetralogy of Fallot is a complex congenital syndrome including pulmonic stenosis, ventricular septal defect, an aorta that receives blood from both the right and left ventricle, and R and LV hypertrophy. And no talk about cardiac anatomy is complete without taking a look at some normal cardiac histology. Cardiac muscle cells appear striated and have a single nucleus. Striated muscle tissue has its contractile fibrils aligned in parallel bundles, forming stripes visible in a microscope. Let's contrast normal cardiac histology with the most common histological cardiac abnormality, the evolution over time of pathologic changes after myocardial infarction. Irreversible myocardial damage occurs within 20 to 30 minutes of severe ischemia. The affected area undergoes coagulative necrosis following with a typical inflammatory response and repair. The changes of coagulative necrosis become evident in the first 6 to 12 hours after infarct. Wavy fibers appear at the periphery of the infarct, shown here at the bottom left of this photomicrograph. By day 2, breakdown of myocardial cells, termed myocytolysis, is seen as pallor of necrotic cardiac myocytes, seen here in the left half of the image. The pallor is caused by disruption of the sarcolemma, resulting in accumulation of salt and water within the myocytes. By days 3 to 4, full-fledged acute inflammatory response is seen within the damaged myocardium. The inflammatory cells, which are granulocytes, lymphocytes, and plasma cells, show up as a sea of blue dots as seen here. Finally, within a few weeks, the necrotic myocytes have been largely phagocytized and replaced by granulation tissues containing loose collagen and abundant capillaries. This completes Session 1, Part B, where I cover the structure and anatomy of the normal heart. We'll continue in Part C with the discussion of some basic cardiac physiology.